Hello, my name is Samira McKeet, and today I will be presenting a startling case of myoclonus and rigidity. Creutzfeldt-Jakob disease is a rare neurodegenerative disease caused by accumulation of abnormal prion proteins that can be sporadic, genetic, or acquired. The disease has an incidence of 1 to 2 new cases per 1 million individuals per year. Symptoms include rapidly progressive decline in cognitive function, cerebellar ataxia, myoclonus, pyramidal and extrapyramidal motor signs, and akinetic mutism in advanced stages. Detection of CJD has proven to be a diagnostic challenge, as the presentation resembles other neurologic conditions such as Alzheimer's dementia, Lewy body dementia, immune-mediated encephalitis, neoplastic syndromes, or infectious encephalitis. Definitive diagnosis of CJD requires neuropathology. However, a probable diagnosis can be made with appropriate neuropsychiatric symptoms, along with supporting lab testing such as real-time quaking-induced conversion, as well as 1433 assay. Here, we demonstrate how the use of a combination of physical exam findings, MRI, and biomarkers can diagnose CJD without invasive brain biopsy. Our case is a 69-year-old female with a past medical history of hypertension, hyperlipidemia, type 2 diabetes, who presents with expressive aphasia, right-sided weakness, and acute encephalopathy. Per her family, the patient was independent at baseline and exhibited a rapid decline in cognitive function over a 2-week period. Exam was significant for left-sided ataxia, 0 out of 5 right upper extremity strength, 1 out of 5 right lower extremity strength, and expressive aphasia. She was unable to follow commands. Decerebrate posturing and spastic tone was seen in all extremities. The patient exhibited spontaneous movement of upper and lower extremities, but did not demonstrate purposeful movement. CT head, CTA head and neck were unremarkable. Brain MRIs showed areas of bilateral cortical restricted diffusion, primarily involving the left side, with faint signal abnormality within the basal ganglia. Continuous EEG showed triphasic waves and encephalopathy, but was negative for epileptiform activity. Hospital course was complicated by myoclonic seizures. Given the myoclonus and rigidity, the patient was empirically initiated on IVIG for treatment of stiff person syndrome. Anti-GAD and anti-ampamycin were negative. Lumbar puncture was negative for infectious etiology. However, CSF was positive for 1433 protein and RTQIC. Along with MRI findings, these biomarkers resulted in a probable diagnosis of CJD. CJD must be considered in patients presenting with rapidly progressive cognitive decline with physical exam findings such as ataxia, startle myoclonus, and rigidity. Early diagnosis is key in preventing iatrogenic transmission, as well as preparing families for end-of-life planning. However, diagnosing CJD is a challenge without invasive testing, such as brain biopsy. MRI and T2-weighted DWI and ADC sequences are highly sensitive for detection of CJD, with 97% diagnostic accuracy, sensitivity of 98%, and specificity of 93%. MRI typically shows hyperintensity in the basal ganglia, thalamus, and cortical gray matter. Biomarkers such as RTQIC and 1433 assay are also very sensitive and specific for CJD. RTQIC can detect pathogenic prion protein in the cerebrospinal fluid for CJD patients with a sensitivity of greater than 80% and a specificity of approximately 98%, whereas the 1433 assay is moderately accurate with approximate sensitivity of 92% and specificity of 80%. Here we demonstrate how a combination of physical exam findings, DWI, MRI, and non-invasive biomarkers can be utilized to diagnose CJD without the use of invasive tests.